I want to share a concept that is super relevant to really any dentist, whether it's a specialist or a general dentist. But it's a concept that really shows the ugly side of itself in restorative dentistry. I just want to dive into it in a little bit more detail. But this playlist where this video is going to be held, I'm going to share deeper concepts. And anytime I have a case that's related to this from any of you guys, I'm going to share it. So this was a case from Austin. The patient was concerned that the new crown that they're going to be placed, so this is an old PFM, they want this darkness replaced. And they wanted the doctor to guarantee that this wouldn't happen again. I guess this was done several years ago, and the patient feels like they didn't get their money's worth, in great part because this showed up. Well, I'm not sure what the average dentist would say, but I think the aggregate comment would be something to the effect of, well, your body just receded. And one of the concepts we try to dive into this channel is really understanding the why to things. You know, if we think back to the concept of functional medicine we went over recently, functional medicine is the version of medicine that really focuses on the origin of the problem and not so much on treating the downstream effects or the symptoms. So we can think of this as one of those functional concepts. The term functional dentistry is something that I've started seeing pop up, and I think it's a nice concept, and I think we might start using that term more on this channel. So how did this happen? Now, before we dive into it deeper and sharing with Austin the answer to the question, let's just take a look at this photo and look at a few things. So I'll start with the recession on this isn't isolated to this tooth. So we can say that this wasn't a biological width impingement or other isolated incidents, but it seems a little bit more generalized, primarily on the two centrals. But we can see some recession here. So what I'm going to do in my mind's eye is say, what biotype is this patient? So is this a thick gingival biotype, or thin, or somewhere in the middle? And the reason why that's important, the thinner the biotype, the more likely we are to have recession based upon a variety of different things. So that's one of the things I'm going to have in my mind's eye. Another is just the thinning right here, and we'll look at the lingual photo shortly. Craze lines here. So I'm starting to think that there's some sort of biomechanical effect going on. And lastly, just the recession. You know, what happened and what caused that. So some concepts that apply to this, dysfunctional envelope of function from Coyce, pathway wear from Spear, lack of long centric from Dawson, entrapment, and many more concepts describe what I call the door doesn't fit in the door frame analogy. And if we want to fully understand this and communicate with our patients, I found this analogy to be super powerful. So if we think of the interaction between the movable part of the system, in this case the door frame, and the fixed part of the system, the maxilla, this interaction is the teeth held onto these entities. So the lower teeth on the mandible, the upper teeth on the maxilla is this interaction here. Now, if the door fits passively, we're not going to have any wear or attrition or mechanical interaction between the door and the door frame. But if they don't fit, one can imagine that we're not only running the risk of having attrition here, but if we can picture in our mind's eye all the way over here, the hinge, we can think of this as the TMJ joint, that hinge can be stressed. And the more and more that we open and close this and we try to force the system, there are downstream effects. And it's those downstream effects that we see as dentists: fractured teeth, periodontal compromise such as recession, TMJ issues, muscle issues as the muscles try to push the door in a way to get it to close easier. All right. And we'll dive into this in greater detail, but I just wanted to introduce this concept of the door doesn't fit in the door frame. Talked about Coyce. Coyce, I think, has probably done the best job of describing the different aspects to this. The envelope of function. This is very different than the envelope of motion, which we're taught in school, the Poiseuille's envelope of motion. The envelope of function is the much more clinically applicable aspect to this. And what the envelope of function discusses is where the mandible goes under normal activity, chewing, swallowing, and speaking. So envelope of motion pretty much just says where could the mandible go if we asked it to go really far, which is not clinically relevant most of the time, at least not in restorative dentistry, maybe in TMD. But this dysfunctional side of things is where this particular patient of Austin's is most relevant. And Coyce talks about, this blue area is the area of the tooth that's at risk for biomechanical breakdown. But I will propose that this is true some or most of the time, but not all of the time, because we will often see pulp stones. We will often see facial bone loss or recession, like in Austin's case, and no recession. So when we see this interaction, we have to know that it manifests itself in many different ways. And recession is the downstream effect that happened with this particular patient. So it's not always attrition. And we could dive into this in a lot more detail, and we will. But I just want to introduce this concept here. One of the other things I often look for is you'll often see recession isolated to a tooth that has a opposing tooth in the other arch that's quote unquote out of position. And what happens is as the patient protrudes forward during protrusive movement, so we have, I digress, but these are the concepts we're going to dive into: static occlusion and dynamic occlusion. In static occlusion, which is MIP, when the patient taps, this may or may not be in the way, but you can equilibrate the patient into MIP where this is not an interference. But you can imagine as soon as they slide forward, if we didn't adjust the dynamic occlusion, that's going to put excess stress on this tooth alone, and you're going to have things that happen, whether it's attrition or recession or all the other things we just talked about. So when you see things like this, bring your attention to the opposing arch, and you'll often see this here. And one of the lectures I saw many years ago that introduced a concept that stuck in my mind's eye: if you have a situation like this versus a well-balanced occlusion during the protrusive movement having equal and balanced contacts, we could use the analogy of this is a stiletto heel, and a well-balanced occlusion is a sneaker. And the analogy was, who would you rather get kicked by? Somebody wearing a stiletto heel or somebody wearing a sneaker? So you can imagine that this, from a biomechanical perspective, is much more, has a higher potential for downstream effects. It's not surprising that you see thinner porcelain in this area here compared to over here. Well, that's because that's the area this is the door frame that's not fitting with the door, this interaction right here, okay? But it also applies to this tooth here. We can see these craze lines here. Craze lines aren't normal. I say they're not normal in a healthy occlusion. They are stress fractures in a dysfunctional or unhealthy occlusion. All right, so here's the lingual view. See how this tooth is buccally positioned? I don't know if this tooth once upon a time was more in line, but I'm just going to make the assumption based on this image from Austin that this tooth has actually been buccally translated through repetitive interaction of this lack of space due to the envelope of function restriction. So we're going to dive into it, but let me just say that when front teeth touch an MIP, there should be little to no contact. And there's many different theories here, but my current belief in most patients is that we should have passive shim stock in MIP from canine to canine. But as passive shim stock means there's about 10 microns of space between, but as soon as we slide forward, that shim stock engages. And we call that's long centric in the Dawson world, freedom from centric in the anterior. But the point is that when patients tap, 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 and we put our fingers on the fronts of these teeth, we shouldn't feel any fremitus, no tapping. If that's true, then we've kind of started the process of creating a door that fits in the door frame. As soon as they slide forward, then we have another arena of the dynamic occlusion we need to adjust. But I think it's good for us in our mind's eye to start with the beginning. All right, so this was a photo from Austin. Cut off the crown and just showing how much space is between here. In MIP, there's enough space. The problem is when that crown was made, most likely the lab that made it in static occlusion. So a patient bites down during the bite registration, during the fabrication of that old PFM, and the lab makes the crown in that static position. What the lab doesn't have, or at least I'm assuming the clinician didn't give this lab the information, is the dynamic occlusion. And we'll dive into how we do that. A protrusive bite record would be a tool that we could use that many of us have heard of in the past. But the point is that labs don't know where this mandible is going to go during swallowing, chewing, and speaking. And if the lab creates too much restriction in this zone by adding too much porcelain, then we're going to have downstream effects, such as recession. So what do we do here? What I shared with Austin is the following. Maybe we'll go to this here. I'm going to table this, but let me just introduce the concept of how to actively put the patient into their envelope of function. We have the patient chew on wax or gum in the posterior, and we place 200 micron paper, articulating paper in the front, and have the patient chew. And anywhere where it marks, we have to reduce. Now that concept is when we're equilibrating a patient's teeth. But here, because we need interocclusal space, we need to ask that question. So the two ways of doing it, one is to create a temporary and then have the patient chew in the back with the 200 micron paper here, and you adjust the temporary until you get to that lingual reduction. Then you take the temp off and you measure it with a caliper or Bowley gauge, and you basically keep doing that until you find out the lingual concavity position. The way I like to do it now is I use prep checks of the thickness that I want, and I have the patient chew. So if I want a zirconia crown, I may, honestly in this case, I would use a 1.5 millimeter prep check. If you don't know what prep checks are, I think they're made by Common Sense Dental. Just type in prep, P-R-E-P, checks, and you can find there's 3 different thicknesses. The 1.5 I would put in between the lingual surface of the tooth, so basically here, and have the patient chew the wax in the back. And what's going to happen is the patient's going to protrude forward during the chewing stroke, and it will interact with the lingual of this through the use of the prep check. And that will give you the clearance so that when you're done adjusting the lingual here, you have enough reduction. So the lab has enough room to create space there. That would be where I'd start. Honestly, this patient needs more attention. They need ortho, and we need to procline these teeth, probably some perio evaluation to see how much attachment loss might be here. So a comprehensive approach is the best answer. But if we wanted to treat this from a single tooth perspective as easily as possible, the use of a prep check and some wax in the posterior teeth to replicate the chewing stroke will get us pretty darn close to where we need to be. When you do that, I have no doubt that this incisal edge of this lower tooth is going to come much closer to the lingual of this tooth here, or the prep, evidenced by that. All right, so that's envelope of function restriction 101. Again, use this concept and remember that there's a system here. This interaction, when the two entities do not relate very well, has downstream effects. So I hope this helps, and if Austin does this and he shares the case, I will definitely update the channel. So I hope this helps. Take care.